everybody, thank you for inviting me. Nice to be here, and I hope that I can make a contribution and clear up a bit of the misconceptions about bariatric surgery. So let's start. My first thing, when I said obesity is a serious disease and must be treated as such, that is by the World Health Organization. It's always funny that if somebody asks you to help them with an article about obesity, and if you tell them that it's a serious disease and it should be treated as such, and when you look at the publication later on in the Huisgenoot or wherever, then the word disease is not there, because people don't want to call it a disease, but it is. 46% of the world's 600 million obese people are from the developing world. And then you can see there that one of every second female BMI more than 25, every third male, 22% of children, 25 to 28% of adolescent girls, and 50% of South Africa will die before 65 from chronic diseases. So my thing is that with HIV and all those epidemics and the TB epidemic and everything that we've got, we're trying to get that under control, and we're already getting that under control with the rollout of antiretrovirals and everything, but the obesity epidemic and the chronic disease and non-communicable diseases is just skyrocketing. So South Africa is becoming a fatter nation. You can see here with the latest studies, the adult women and adult men. So South Africa is catching up with America, surpassing them. But the burden of disease. Okay, the important thing about obesity is that it's not only the obesity itself, but the burden of disease attributable to excess body weight is 87% for type 2 diabetes. So 87% of your type 2 diabetics is type 2 diabetes because of insulin resistance and because of obesity. So, and I can go on 68% hypertensive, 61 endometrial cancer. So you can see through the whole list of things that if you don't treat the obesity, you're going to struggle with the rest of the diseases. And if I don't make any point today, is that this slide is a very common slide that you all commonly see. I think that if you can see that obesity is in the center, and then the comorbidities is basically attached to that. We as doctors in private practice and in the public sector, we're very well trained to treat the diabetes. We've got lists and we've got lots of guidelines and everything that's been updated yearly and so on. But so we can treat that, and unfortunately at this stage, because there's no medication for obesity, that is where we have to focus. You can't ignore it. But I think the main thing is that we must start thinking of treating the central problem and not like avoiding that because we feel helpless, and we just focus on the comorbidities. So I think if there's one thing that I can bring home today is that think of that as your center point of the problem, and your comorbidities is just attached to that. So we have to sort of get that thing right, otherwise we're not going to get stuck anywhere. And then with the diabetes, I also had a center of diabetes excellence, and the rising levels of obesity are likely to drive the prevalence of diabetes much higher than the present forecast, because they didn't take the obesity epidemic into account. And your diabetes is your most preventable consequence of the obesity epidemic. Impact on society. it may contribute to as many preventable diseases as cigarette smoking. Your healthcare cost is between 5 and 8% of the health budget. And the impact on indirect costs like absence from work and things like that is also considerable. At a BMI of 45, your life expectancy will be decreased by 13 years if you're a white man, and 20 years if you're a black man, and so it goes on. So there's also a huge impact on mobility and life expectancy. Obesity is strongly associated with the metabolic syndrome. I think you all know the metabolic syndrome. There's a lot of focus on the metabolic syndrome. I think it's very important, but still I think it's very important to realize that obesity, central obesity, abdominal circumference is the main thing, plus 2 of the other factors. So the BMI is a simple index for your weight to height reduce. Everybody knows the BMI. The BMI of 25 to 29 overweight, and then your obese class 1, 30 to 35, 35 to 40, and then more than 40 your obese class 3 patients. So, this is not always that accurate, because you must think of athletes who've got a lot of muscle mass, and then sometimes you get a skinny woman with sarcopenic obesity with a central obesity, and then the BMI is normal, but actually if you do other parameters like cholesterol and so on, she's actually very sick. So BMI is not always, must take everything into account. And I think that pathogenesis, just to see that it's much more than not moving enough or just eating too much. I mean, there's a lot of other factors, hereditary factors, environmental factors, the environment, insulin resistance. I said it's beyond the scope to go into that a lot of detail, but I think still, if you ask a doctor now that just graduated, maybe still tired because it was after the casualty session for the night, but then they're lazy and they're not eating enough, lack of willpower. So it's not that easy. If it was that easy, we wouldn't be here today. Maybe insulin resistance. Maybe say something about that, because in the news lately that insulin resistance is the cause of obesity. I think most of the endocrinologists at this stage, with the research that we've got at this stage, is that peripheral insulin resistance is because of obesity and not the other way around, as is in the press nowadays, and in that red book and everything that we. So there's a genetic predisposition, dysfunction of your adipose tissue, excess visceral fat, and then your insulin resistance, leading to beta cell destruction, and then leading to type 2 diabetes. Okay, the treatment options of obesity have matured over the last decade to take into account the consideration BMI and the comorbidities. So we take a step care approach, and we attempt highly structured lifestyle modification, and then we discuss pharmacotherapy with the patients. Although I'm waiting for at least 2 years data on the medication, because you just start using medication or know everything about it, then they take it off the market for obesity. At this stage, only orlistat is approved for long-term treatment of obesity. There's a few of them coming on the market now, but I think we'll wait to see if they're effective. Then this is very important. Patients for whom lifestyle changes are successfully, those with clinical severe obesity, should be informed about the risk and the benefits of bariatric surgery. We think of the bariatric surgeries that was done many years ago in South Africa, people coming with severe complications, kidney stones, malnutrition, diarrhea, stuff like that. I mean, there's been evolution of the types of surgery that's been done. Those surgery that gave bariatric surgery a bad name is banned in South Africa. So I think you have to give a patient that option if his BMI is above a certain level and you can't get anywhere with him with your lifestyle changes and with your diet. You have to give the patient that option. But the modifiable components of energy balance is energy intake, expenditure, thermogenesis. I don't have to give you a lecture here. You think you know more about calories and how much in and how much out to lose weight. But these things cannot be addressed in isolation. Problem with this weight loss is usually 3 to 6 months, then it tails off. And that's why it's very important that this program should address weight maintenance after weight loss. Because weight cycling is a serious thing. I think you've read somewhere that dieting can make you fat. That's the thing with weight cycling, because go back. If you lose weight, you lose your lean body mass and you lose fat. And then as soon as you start gaining weight again, your fat catches up first. But your lean body mass also wants to get back to where it was, because it's biologically ingrained. And then you keep on eating, your fat is already there, but you keep on eating to get your lean body mass back to normal, and then you overshoot with the fat. And that's with weight cycling. So gradually your weight goes up and up with weight cycling. So please, if we give somebody a weight loss program, we must do weight maintenance as well, because otherwise you just make them fatter. And caloric restriction triggers several biological adaptations to prevent starvation. So what I'm meaning with this, if you trigger this with starvation, the body's mechanism to survive kicks in. So if you've got a ingrained, like your body weight was 120 for 20 years, and you've tried everything, weightless, everything under the sun, Euromine, exercise 4 hours a day, and you can't lose the weight. I mean, there's actually, it's a biological thing. So if you don't maintain that, you always go back to that set point. So improved lifestyle changes might be sufficient for lasting reductions in body weight prior to sustained obesity. So the point here is we have to start early. We have to start with children in school. We have to start with this integrated school programs. They should go to the schools and teach at school level and community level. So you have to prevent it, because once obesity is established, your body weight seems to be stamped in and defended. Your body defends that set point. So well, I don't want to say too much about diet, because but I think all this thing about high fat, low fat, high carb, low carb, can go on about that for many years, but the main thing is that you basically need adequate protein intake. And the protein is basically the only one that changes your intestinal peptides, your PYY, GLP-1, and things like that. So, but I'll leave that to physical activity. I first started with sport medicine, but eventually my interest went over into the prevention and treatment of lifestyle chronic diseases of lifestyle. And then 60 minutes of physical activity most days of the week, minimum 3 to 4 times per week, is an effective tool. Even if some people, or Gary Taubes, or in one of the books say you don't have to exercise, because if you exercise you eat more and then you gain weight, so don't exercise. You just rather lie in bed and do nothing, then you're not going to gain weight. But it's a bit of nonsense. Combination of resistance training and aerobic exercise is needed to optimize reduction in visual adiposity. Lifestyle medication as an isolated tool is a high failure rate, and less than 5% of patients will remain successful in 5 years. So does that mean that lifestyle is not, modification is not necessary? We shouldn't try it because only 5%. I think if you reach 5% of patients worldwide, it's quite a few kilograms that you can lose. So the potential benefits of a moderate 5 to 10% weight loss in high-risk patients equals 30% visceral fat tissue loss, and your total mortality is reduced, 50% of diabetes, your blood pressure reduction, and also improvement in your cholesterol profile. So it is worthwhile because people can use a little bit of less glucophage, and maybe it's like replacing one of your blood pressure tablets, and also maybe a lower dose of statins, which is also nowadays becoming a really... My patient doesn't want to take it anymore because in America it's causing Alzheimer's. So we try to keep it at the lowest possible dose, so you can... as I said in my introduction with the pharmacotherapy, the recently approved drugs are still pending, but you have to discuss the possibility of pharmacotherapy with the patient. Surgical treatment, we recommend surgery when appropriate, because bariatric surgery is actually the only long-term effective treatment for obesity available at this stage. Not all obese patients are suitable surgical candidates, and you need an experienced team of medical experts in obesity management to assess the patient before and after surgery. The long-term preparation before and the decision whether to go for the surgery and then go for the surgery and the post-operative care, everybody in the team knows what they're doing, and it's very important that you like if you send somebody to a center, make sure that support is there, because there are excellent surgeons that will take the patient, do the surgery, and then they never see the patient, well, they don't really care what's happening next. At Waterfall City Hospital, there is kind of the Center of Excellence of Metabolic Surgery, where I'm working part-time. There's 3 types of bariatric surgery. We've got your restrictive procedures to limit the intake. There's no intestinal bypass. It's like gastric banding and sleeve hysterectomy. At Waterfall City, we actually remove quite a lot of banding, but we don't do it there because it's not really long-term that effective. Procedures altering gastrointestinal peptides with gastric restriction to ruin wide gastric bypass. This is the amazing part of this surgery, the Roux-en-Y for like diabetics and hypertension and so on. You change the peptides, the GLP-1, the PYY, oxytocin in the intestine. So the patient will be off his diabetic treatment before he starts losing weight. So that is actually that's amazing, because you have to see that to believe it. The malabsorption procedures involve bypassing a portion of the intestine. There we do the video pancreatic diversion of the duodenal switch. It's a much bigger procedure, much more complicated, so we reserve that for the patients with a very high BMI and a lot of comorbidities. Just a few pictures for gastric banding, the Roux-en-Y gastric bypass, where you just basically pull that, make a small pouch, you cut this off there, you pull this up and attach it to the small pouch, and so you bypass this part of the stomach, but you still get all the gall and the pancreatic enzymes and everything that joins there. The gastric sleeve, which is making basically the stomach smaller, and then the BPD, which is the bigger procedure, what I was talking about. The surgeries, metabolic surgeries that was done, you can see from one in 1997 up to 529 in 2014. I think also it's important, if you refer somebody, there are a few of the centers in South Africa, to send somebody to an accredited center with an experienced surgeon, because then you get like less-sided complications. Everything just sort of works better if they're experienced and it's an accredited center. Gastric bypass surgery will induce weight by these three mechanisms: restrictions of volume, your gastric outlet is bypassed, and as I said, induction of satiety by altering the gut peptide PYY and GLP-1. The selection, I think this is what Gerda actually asked me to say, is the selection of the obese patients without clinical or psychological contraindications. So they go through a psychologist, they see the dietitian, they see the psychologist, if it's necessary, they see the psychiatrist, they see the endocrinologist, they see the surgeon. So it's a whole team effort. So no patients go into surgery if there's any contraindications for them. Patients with a BMI over 40, the medical aids will pay 80% of the surgery. Most medical aids without any comorbidities. For patients with a BMI of over 35, there have to be some comorbidities that was not effectively treated with normal medication. And then patients with a BMI of more than 30 with poorly controlled diabetes. It's amazing, when I was doing my CDE patients, I will always, at the end of the month, if I work at a loss, that because it's more like a capitation system, if I work at a loss, that it's usually the obese patients, because they are on hundreds of units of insulin. And so if even those patients after the surgery will end up without insulin, or maybe sometimes 10 units of Lantus or something like that. So it is actually a lot of cost saving in the long term. Contraindications, as I said, severe cognitive dysfunction and psychosis, advanced liver disease, uncontrolled coronary artery disease, or severe obstructive apnea. This is a very good surgery for snoring as well. The patient will stop snoring after. Okay. So weight loss changes, just quickly. The gastric bypass, 32%, and then 27% after 15 years. So if they come for their follow-ups and they follow the guidelines and they follow the rules, it's not like people say that anyway going to gain all the weight again. The resolution of the major comorbidities, that's I think one of the most important things to realize, that the diabetes with gastric bypass 84%, cholesterol 97%, hypertension 68%, sleep apnea 80%. So with the BPD it's even more. But as I said, we reserve that for the very morbid obese patients. There's just some slides about the diabetes. resolution. You can see there's a big difference between the medical treatment and the surgery. Quality of life improve with the surgery. People can start scuba diving again, they start running again, they start being active again, so they can't believe that they've got so much energy again. And so that emotional well-being, everything improve. I mean, people that are there, so basically have to go for knee surgery or knee replacements, back surgery, lose the weight, and the other doesn't have to do that anymore, or they can postpone that for another 10 years. And then the gratitude and expression of thanks from the patients is sometimes overwhelming. They can sometimes, if you ask them if they've got any what they shouldn't have done it or something, so the only thing that they think is that they should have done it sooner. This doesn't mean that there's no complications with surgery. Some of the patients does need revision, or some of them get malabsorption if they don't eat enough proteins and things. So it's not like, but the gratitude from the patient is actually overwhelming. And then the medical profession has got almost no training in obesity in the past. So I think that's something that's have to change. And just doctors are not really aware of what this can offer their patients, and then they don't tell them that this is an option. So I think if you can just tell your patients, if you tried everything and you don't get anywhere, just tell them this is an option, and refer them to somebody that can give them that option. And then I think a multi-team thing, I think with a multidisciplinary team that we do in the centers is actually I think every GP practice should have an obesity specialist and a multidisciplinary team. If there's an obesity specialist, nurse, a dietitian, a psychologist, and also exercise specialist. I think if everybody tried to be separate, the doctor gives the medication and the dietitian gives the advice on the diet, and somebody separate. I think if there's a team effort, or maybe just, even if it's not in the same center, but a bit of more communication about obesity patients, we will be much more effective. Okay. Thank you. That's my thank you slide.